Welcome to the image analysis of the scapula. We're going to look at common projections of the AP and lateral scapula. We're going to review the image analysis guidelines as well as common positioning errors and how to take corrective action. Image analysis guidelines for the AP projection of the scapula state that the anterior and posterior margins of the glenoid cavity are nearly superimposed. Lateral scapular border is seen without thoracic cavity superimposition, while the thoracic cavity is superimposing the vertebral border. The superior angle of the scapula is seen without clavicular superimposition. The humeral shaft demonstrates a 90 degrees of abduction. The scapula is demonstrated without longitudinal foreshortening. The superior scapular angle is slightly inferior to the clavicle. The midscapular body is at the center of the exposure field. The scapula is included within the exposure field. The scapular structure situated in the thorax is demonstrated with adequate contrast resolution. Here are those image analysis guidelines for your review. First, I'd like to take a closer look at humeral abduction and how it affects scapular positioning on a radiographic image. Humeral abduction involves the combined movement at the glenohumeral joint and the scapulothoracic articulation with a motion of 2 parts glenohumeral to 1 part scapulothoracic. As the arm abducts, the lateral scapula is drawn away from the thoracic cage and the glenoid cavity shifts superiorly, as you can see in the first projection. During the first 60 degrees of abduction, most of that motion comes from the glenohumeral joint with minimal scapular movement. It's only with at least 90 degrees of humeral abduction that we can clearly visualize the entire lateral border of the scapula without thoracic superimposition, and see the supraspinatus fossa and superior angle free from the clavicular overlap. When the arm is abducted less than 60 degrees, as in this second projection, the infralateral scapular border remains superimposed by the thorax, and the clavicle overlaps the superior scapular angle, reducing that visibility of the critical anatomy of interest. For optimal imaging, proper arm positioning is essential to minimize that superimposition and clearly demonstrate those scapular structures. So now let's explore how shoulder retraction affects the quality of AP scapula projection. When the affected arm is simply placed at the patient's side, the scapular body sits at a 35 to 45 degree angle to the IR, which results in this transverse foreshortening of the scapula. To minimize this distortion and improve visualization of the scapular body, you should adjust the positioning so that the patient knees can be either placed supine, or if upright, we need to ensure there's proper retraction. The humerus is abducted at that full 90 degrees, the elbow is flexed, and the hand is supinated by externally rotating that arm. Abducting that arm allows the scapula to glide laterally around the thoracic cage, moving the inferior angle and lateral body of the scapula away from the thorax. Flexing the elbow and supinating that hand encourages the shoulder retraction by applying pressure to that lateral scapular body and drawing it posteriorly and reducing some of that foreshortening. Taking the image with a patient supine greatly increases shoulder retraction due to gravity. However, if you're doing this position standing, you just have to ensure that you are getting that shoulder retracted. So how do we evaluate the quality of the shoulder retraction? You want to look at the amount of foreshortening in the scapular body, and you also want to look at the visibility of the glenoid cavity. If the arm is not adequately abducted and the shoulder remains unretracted, the image will show excessive foreshortening and the glenoid cavity will appear on end, limiting that diagnostic clarity, as you can see in this projection. We'll go back to the previous appropriately positioned AP scapular projection, and you can see the glenoid cavity is not as visible as on the insufficiently retracted shoulder. Go ahead and review this practice analysis and answer the following question. Let's review this practice analysis together. We're looking for an AP projection of the scapula. We want to look at the position of the lateral border and the inferior angle of the scapula. In this case, both are superimposed by the thoracic cage, indicating to us that the arm was not sufficiently abducted. In order to make a corrective action here, we need to abduct the humerus to a 90 degrees angle with the torso in order to adequately visualize the anatomy of interest. Now let's move on to the lateral projection of the scapula. Image analysis guidelines for the lateral projection of the scapula state that the superior scapular angle is demonstrated just inferior to the clavicle. The longitudinal scapular body is demonstrated without foreshortening, and the superior scapular body is seen without overlap of the humeral head or glenoid cavity. The scapular body is in a lateral projection with superimposed lateral and vertebral scapular borders. The mid-scapular body is at the center of the exposure field. The entire scapula is included within the exposure field. Here are those image analysis guidelines. I have also included a image of how to identify the scapular borders. If you recall from the shoulder image analysis that the lateral scapular border is easily identified because it has a thicker border with two cortical lines, whereas the medial border has a thinner border with one cortical line. Go ahead and review the practice analysis and answer the following question. Let's review this practice analysis together of this lateral scapula. In this projection, you want to ensure that you see the leg of this scapula, which is the lateral border, and the vertebral border superimposed. In this case, they are not. The medial border is demonstrated closer to the thorax, which should indicate to you we are under rotated. We're going to need to increase obliquity to ensure superimposition of those borders. Also, the text indicates that there is a little excessive abduction of the arm. So, and this is indicated by the superior scapular angle being placed inferior to the coracoid. In order to correct this, we need to just abduct that arm to 90 degrees. So we would decrease the abduction if it was excessive, and take the next projection so that the patient is adequately positioned. This concludes the scapula image analysis. If there's any questions, please feel free to reach out.